We can see it.
All right, perfect. So I will give a little bit more background as we kind of go through the presentation. There's a lot of information today. We also have some room for some kind of facilitated discussion. We're hoping you'll be active participants in that discussion, really to get to know you folks a little bit better, understand some of the pressures on your environment. But today we're going to be talking about a process that we've taken a number of your peer PCAs or statewide associations through to better understand the role that networks might play in how you interact in the payment environment that you're currently facing, as well as the one that's kind of continually evolving around the concept of value-based reimbursement. We work almost exclusively with federally qualified health centers. We do some work with others that support them, so foundations, networks, PCAs, et cetera. But really, we are attempting and striving to help health centers really remain at the forefront of healthcare delivery as value-based payments roll out. And that really stems from kind of our long-held belief that federally qualified health centers in particular are about as well prepared to be high-value contributors under value-based reimbursement systems, given some of their legacy and history around managing the health of populations. So with that said, we don't necessarily want the shift to value-based reimbursement to be kind of an opportunity for competitors to come in and move in on some of that capability when we're probably better equipped to rise to the challenge, receive the additional investment, and then ultimately expand our capabilities around some of the value-based concepts that we'll talk about today. There are three of us on the call. I won't have the others introduce themselves in person. I'll do a quick intro for them, and you may hear from them from time to time. Amanda's going to actually help me do some of the facilitation, and Samantha's here really to make sure that we capture the kind of the richness of the conversation today. I'm Andrew Principe. Amanda Stangus and I founded the company. Samantha's been with us really pretty close to the beginning. And this team has worked pretty consistently across the country with PCAs. So we bring a lot of experience. Each of us has a little bit different area of focus in this work, but you'll get to know each of us over the course of this engagement. And feel free, we've given you our contact information if you wish to reach out after this session to ask any questions, clarify anything, et cetera. So just a quick discussion of why we think you're here. And when we get into some of the facilitated discussion, I'd love to hear a little bit more if there's other thoughts. But you've contemplated working together to leverage scale periodically over the last couple of years. And your market is continually evolving or continuing to evolve. And we'll talk a little bit about that evolution. But there are some signs in the market right now that might suggest that that kind of coordinated approach to working with payers might make more sense at the current time. So we feel that there are potentially some opportunities to kind of capitalize on some of those trends, and we're going to be talking about those today. This is a kickoff session to what you may decide is a longer process. We've worked with the PCA to define what a full discovery process might look like, and we're going to take you through that today. But ultimately, today's discussion is really to help tee up a conversation as to whether you wish to dig deeper and explore. So today you're going to learn, we're going to start with some background and some important concepts around your market and how it's changing. We're then going to take a look at networks themselves and how they operate and really kind of dig into what some of your peers have done. And then we're going to talk about that process. So hopefully by the end of the day today, you'll have a pretty good understanding of why you might want to go down this process and also what the process itself will actually look like. It's very possible you've seen me present this before, but I think it's an important starting point for the conversation. As we know that despite numerous attempts to either repeal or weaken the Affordable Care Act, it is still the overarching law of the land as it relates to how healthcare is organized in this country. And a huge oversimplification, but also a way of really trying to take politics out of the discussion about the ACA. The ACA had a couple of very simple goals, and even though it's a fairly complex set of of laws, those goals are really aligned with eliminating some of the non-value-based care, if you will, that's being delivered all over the country that's leading to significantly higher costs. And non-value-based is not necessarily always a judgment of whether a good outcome was achieved, although I'll give you some examples of bad outcomes that we pay for a lot as taxpayers, and I'm sure you're very familiar with them. But non-value-based essentially means that the payments are linked to, exclusively to volume. So if I perform 3 bypass surgeries, I get paid for 3 bypass surgeries. There's no indication or no evaluation of whether those bypass surgeries were actually indicated, whether alternative treatments were possible, et cetera. And so we have kind of a fundamental challenge where we want to shift more to value, and it's very hard to do so. There are a couple of specific types of financial resources that generally are not linked particularly well with value. DISH is disproportionate share to hospital payments, typically paid after the fact to hospitals who bear a disproportionate share of the uninsured, uncompensated care pools, even patient responsibility, because as we know, patients, if they are uninsured, are not necessarily making proactive and preventive medical decisions or medical and healthcare investments at the level we wish that they would. So how does the ACA go about doing it? Through a very simple concept, through insurance. It could have been a public option, and it could have even involved some public option. But the goal or the structure that the ACA took was to push as many people into insurance as possible. One of the key features or characteristics of insurance is that insurance links a specific amount of financial resource to a specific individual. And so as we talk about different types of insurance companies, what I want you to always think is that each insurance company, for the most part, is taking a fixed amount of money based on an individual person's characteristic, and their goal or their desire is to have as many patients as possible and to blend that risk so that the financial resources that they get for that pool of patients ultimately is sufficient to not only care for all of those patients, but in many cases to produce profits for those insurance companies. That has led to a fairly rapid rise in what we refer to as private managed care enterprises. And I want to talk about 3 of them. One, of course, is traditional managed care. You have this operating in your Medicaid program, and it is going to be reprocured sometime in the very near future. And we'll talk about how that really represents a good opportunity to start thinking about how you wish to engage with those traditional managed care plans. We're also, I believe, very familiar with the marketplace plans. I think we had a much higher expectation for how those might impact health centers. And certainly while it has to some extent, I don't know that necessarily some of our concerns around PPS and the like came true, because I think generally speaking, we have a relatively small percentage of the population that we serve that are in the marketplace. And then provider organized managed care. The most common name you'll have heard in this arena is accountable care organizations, or ACOs. And each of these represents a different way of essentially taking that insurance money, linking it to a person, and then linking that person to an organization that is obligated to essentially provision all the care that that person needs within the limits of those financial resources. And so regardless of what the model looks like, this rise of managed care, this rise of the marketplace plans, the overall reduction in the uninsured does create a couple of hot topics for health centers. And we've been talking about these for the last couple of years, but the idea that we need to continually shift to population health models of care that start to dissociate, again, volume from value. Maybe we don't need to use as many encounters if we can use telehealth and remote monitoring, for example. But then how do we get paid? Because our payment model is primarily driven by our encounters. So we want to look at that in conjunction with looking at how value-based payment arrangements work, and really how to make them work as effectively as possible, not just for our health centers, but also for the population of people that we serve. And of course, that creates a real interest and something a lot of your peers have studied and looked at, and many of them have moved forward on, in creating organizations such as ACOs and IPAs, which is really the crux of our conversation today. So even though we're going to focus primarily on those concepts or network type concepts, it's important to understand where it fits in to this overall trend toward driving better cost accountability through value-based payment arrangements, thus loosening up essentially restrictions on how we deliver care and allowing us to operate under population health models of care, ideally through some type of network that secures us the financial resources we need to do that. So that's kind of the overarching story, and we're going to kind of continue to play that out as we speak today. I did forget to mention, we are going to ask you to stay muted while I'm presenting, but I'm more than happy to answer questions in line or make comments on thoughts you have in line if you include them in the chat feature. I'll keep an eye out. I'll also ask my team to pipe up if I happen to miss something. But if you do have questions prior to when we take some breaks for discussion, please don't hesitate to put them in chat. So we see a fairly typical transition occur in states that have essentially moved forward and adopted some of the principles of the ACA. And so these trends, and they tend to kind of go in this order, and for valid reasons. Sometimes they, they may go a little bit out of order, but generally speaking, if a state were to select to expand Medicaid, as you folks know, they're taking a fairly substantial federal subsidy to offset 90% of the cost of the expansion population for a period of time. And thus are able to provide Medicaid coverage to 138% of the federal poverty level. As a result, and in response to them looking for some level of cost containment, two things start to happen. First, they typically select and or expand a managed care model. I talked about kind of the most prominent managed care models earlier, private Medicaid managed care, marketplace plans. Some states have elected to buy people into the marketplace for the expansion population, and of course ACOs or other direct to provider type managed care models. Your state is no different. We will talk about your private managed care model and kind of how it's evolving. But one of the things that occurs pretty quickly thereafter, and this is really in response to the fact that the state, although in many cases would wish to maintain the expanded Medicaid, does eventually have to pick up a larger portion of the tab. And as such, is really looking to, if you will, bend the cost curve or slow essentially the growth of cost associated with healthcare, and look to the managed care organizations, regardless of whether they're ACOs or private managed care organizations, that to really look to them to create systems that reward financial and clinical value within the provider networks that they contract with. So in all 50 states, some variation of this is occurring, even in states that haven't expanded Medicaid, although there are fewer and fewer of those every time there's a ballot initiative. I think we're adding 2 or 3 this year. But even if the state didn't expand Medicaid, some of these trends still occur. And actually, we're going to use Missouri, a state that has not expanded Medicaid, as a very successful network model because the managed care environment combined with the state's wishes to see value-based contracting in managed care really strongly suggested that a network would be a successful strategy. So let's talk a little bit about some of the trends in your market that we see as kind of driving towards or down that same kind of trajectory, and really why we think it's a good idea to be at least exploring whether a network might make sense. And this is typically the point where I tell you that we have no preconceived conclusions as to whether it does or doesn't. We also think it's a really important time in the history of health centers, but also specifically based on some of these trends that you make sure that you understand. And if you decide you don't wish to kind of collaborate under a network model, at least make that decision with good information about what that would look like and what its benefits and costs might be. So your Medicaid program is undergoing, it's actually in process to award essentially a new set of managed care contracts. That usually leads to some churn. There could be plans entering, could be plans leaving. And even if there are not plans entering or leaving, there will be changes or fundamental changes to that contract between the state and those managed care plans. And those changes often revolve around raising expectations for how those plans are managing cost and quality outcomes. And in many cases, those changes do require the plans to show an increased use of value-based payment models with the providers that they contract with. So we think that alone, that potential for change, particularly if a new entrant were to come into the market, or if the existing plans had suddenly saw more pressure to contract under value-based models, really is a good time to understand your options, specifically around how to have a seat at that table in discussing what those payment options might look like. Part of what we want to look at is a little bit of potential leverage for a network, and we're going to talk about how that works in the contracting process. But we also want to say that, given some of the realities, both the size of the population in Nevada, the size of the population you serve, we may not be looking necessarily at a true slam dunk business case. And we're going to help take you through understanding the potential business case and how it relates to the total number of patients that you serve. There are still lots of options for how to collaborate, even if holding joint contracts doesn't make the most sense, but we are going to explore models that do both. One in which the value-based contracts flow through the network, the other where the network simply supports your organization in administering and even securing value-based contracts. There's a lot more to learn about what's going on in Nevada, what's going on specifically at your health centers. So like I said, there's no preconceived notion that you should build a network, but we will lay out kind of a process for understanding what that looks like, so you can really think through whether it makes sense to go down that road and explore further. We took a look at 2018 UDS data. It's the most currently public available data. We also know that you folks have grown, and so and when we get into some of the facilitated discussion, we may want to talk a little bit about growth, specifically where you've had growth over the last couple of years. And we will actually be conducting, should you wish to proceed and explore this process more fully, we will be conducting a survey that's really intended to understand more of a steady state, not just of how many patients you're serving, but also to really understand the plans that you're collaborating with, essentially to serve those patients. This is, you do have a relatively small membership, and that's okay, but it does create a couple of situations that we want to be clear about up front. First and foremost, we really have to look at how these numbers get divided up. Your peers in Wisconsin, as an example, have a similar number of health center organizations operating in their state, but they have 9 different managed care plans that they interact with. So the patients get divided up much more into much smaller buckets, making it hard to have the type of either leverage or risk spreading, if you will, across essentially those smaller pools of patients. Since you have relatively few statewide plans, it's very likely that with 38,000 Medicaid patients, and I know that number is probably going to be a little bit higher, that there is in fact likely some good opportunities to work together and seek kind of joint contracts. But we're going to explore that in more detail through the survey. The third-party insurers, assuming that there's probably one or two key players, and then a lot more that make up the remainder. Again, there may be some opportunities to explore value-based purchasing in that environment as well. I would suggest that Medicare might be a little bit higher of a hill to climb with less than 7,200 patients. I would suspect that an ACO or a shared savings program with Medicare may not be on the table, but we will explore if a percentage of that population is in Medicare Advantage, there may be some opportunities then to work with those plans as well. And lastly, there are a couple of things that I think we'd like to consider with you folks as we go through the process that will help strengthen the business case for moving forward. So a couple of other considerations are there potentially other partners that you would want to think about involving down the road? So if you build a good infrastructure for managing managed care relationships and managed care contracts, could you look at expanding that footprint and thus increasing the return on investment? Does growth, is your growth rate and or your percentage of the total population served in and of itself enough to give you considerable leverage? So typically, let me just give a little bit of a benchmark. In order to do anything of particular interest with an individual plan, a network should have really at least 5,000 unique covered lives with that plan. So if you took your number here of, let's call it 39,000 and just divided it by 3, every one of those plans would be above that threshold. Actually, 10,000 is another break point where you can start to look at different types of risk sharing arrangements. So clearly we think there's an opportunity there, but also looking at just how much of, for example, a dual eligible population you might be serving, even with relatively small numbers of patients, there may be ways of creating value-based payment options, even though the patient count itself may be relatively low. But if you're growing rapidly and therefore can expand access to plans, or if the percentage of the total Medicaid population you're serving is very high, you may have more leverage than we would typically expect with roughly 13,000 on average patients per plan. Lastly, is that you do still have a fairly large uninsured population, and there may be some opportunities. Now, granted, the PCA may already be working on these, and that may be an adequate solution for addressing those, but you may have the opportunity to explore additional ways of crafting value-based components to interacting essentially with the uninsured population. So we're going to take a little bit of a pivot and actually start looking at some fairly technical information. We think it's important background information. We're going to start with value-based payments, and then we're going to dive into the details of networks and how networks operate. I don't see anything coming through the chat. I'm just going to pause real quick in case folks did want to pose any questions thus far. Otherwise, I'm going to move ahead. Give you about 30 seconds and then we'll move forward. All right. I'm not seeing anything coming through. So let's move ahead and talk about value-based models. And I'm sure you've heard and seen a lot. So we'll keep this conversation fairly brief. I do think that we put a little bit of interesting perspective or unique perspective on this, having worked with so many of your peers. But we also know we don't want to inundate you with information you may already have some exposure to. Basically, value-based payments are payments that are intended to reward good performance, usually measured as either clinical outcomes or total cost of care, and sanction essentially poor performance against those same indicators. And it's typically done to create, if you will, growth opportunities for providers that can demonstrate effectiveness in managing cost and outcomes at a high level. In addition, value-based payments can serve to simply allow some flexibility to do things that are aligned with value, for example, in-home visits for certain patients that otherwise might not be cost covered in a non-value-based arrangement. If you're not familiar with the Healthcare Payment Learning and Action Network, I would suggest at least spending a little time on their website. They are a public-private consortia. They do pretty good work on kind of defining and categorizing different value-based payment models. And the reason why I think it's important for you to have at least some exposure to this organization is because the state Medicaid directors typically rely on their publications for making determinations about the types of payment programs they'd like to see within their state. So just as an example, we recently reviewed an RFP for a Medicaid managed care procurement that actually had specific percentages of total expenditure that the state was looking for the health plans to spend in actually category 3, and we'll talk about what category 3 is in a second, but they directly in the RFP reference the work of the HCP land. So we think it's an important body of knowledge that you should have some familiarity with. Let's talk about the categories. As a general rule, the risk and reward opportunity increases as you move from left to right. Category 1 is typically described as fee-for-service with no link to quality and value. And I would argue strongly that most health centers probably aren't precisely in category 1 alone, but in many cases, in relatively new managed care environments, we do find a lot maybe operating purely in category 1. Category 2 starts to link to value, and we're going to look at some specific category 2 models, or at least one category 2 model in a second. And these remain highly compatible with PPS, but create opportunities for you to move beyond essentially encounters as your predominant source of revenue and really into certain incentives around achieving certain outcomes. Category 3, and again, we'll look at a couple of these, gets into APMs with shared savings. And typically, again, these can be done very much compatible with PPS, but introduce essentially some financial upside or financial upside and downside based on helping the managed care organization, in the case of your environment, achieve certain cost goals and the associated outcome goals. And category 4 really gets into population-based payment models that start to take on some of the characteristics, for example, of capitation, whereby the network or the individual organization in these models has a fairly unlimited exposure to risk. It's never truly unlimited, but also the reward of keeping whatever financial resources are saved as a result of their work. There's no right trajectory. The goal isn't to get health centers as quickly as possible to category 4C. That is just not the goal, essentially, that we're trying to achieve. If anything, one of the major values that your peers have seen in networks is actually using the leverage associated with those networks to determine where they want to be on this trajectory. So we've seen networks successfully slow a drive towards category 4 simply because they had the leverage to do so. I'm going to talk really at a high level again about a couple of these. Category 2, as we mentioned, breaks into 3 categories. The first we love. It's referred to as infrastructure payments. Typically we would call these care coordination payments, and they're usually guaranteed. And you can use them for whatever you want, but the hope is that you'll invest them in things like telehealth, remote monitoring, in-home visits, clinical pharmacists, like the kind of things that go outside of the direct provisioning of primary care and really into maintaining wellness. They're typically made on a per member per month basis, but sometimes they're paid after the fact. Category 2B is simply getting paid to report outcomes. Category 2C is the most common, which is getting paid to demonstrate a specific level of performance against certain outcomes. And so it's a relatively basic model, and we see a lot of it particularly as a first pass at interacting with managed care plans. Category 3, as we mentioned, starts to introduce an important concept, which is referred to as total cost of care. So a Category 3A model is a upside-only shared savings model. And what it will allow a network or an individual organization to do is to receive a financial reward if they successfully manage the costs of a population below the expected costs of said population through better care coordination and care management. And then 3B really gets into having some potential downside risk. So in 3A, if I save money, I get to keep some of it. In 3B, if I lose money, I have to pay some of it back. And that may not sound particularly desirable at this point, but we do see a trend where more and more of these shared savings programs are moving in that direction. Category 4 has a couple of different models, and we're not going to talk about all of them. I do want to just mention, though, that there are some valid reasons to consider certain Category 4 payment models. One of them is, well, we've seen health centers do very well, for example, in bundled payments for delivery, pre-delivery, delivery, and postpartum care, operating on a bundled payment model, for example, because our outcomes are good and because we can manage those costs probably better than other sites. We've seen that. We've also seen health centers operate under a full capitation model within what's known as the PACE program, which is a Medicare program focused on the elderly, where they're just very effective at managing total cost of care, and thus keep or essentially reap the financial reward of doing so efficiently. So Category 4B would be kind of like that bundled payment that I talked about for a specific set of services, and then 4C is when you actually take a bundled payment for, in essence, the entire set of services. So we're going to switch gears now, and for the first time, we are going to actually ask you to open up the phone lines, and Amanda's going to do a little bit of facilitation here. It's going to take me a second, I think, to get situated, because I'm going to be taking notes as we go. Amanda, are you on?
Yep, I am. Good afternoon or good morning, everybody. So Andy's going to, pull up some. What we want to do at this point is to get a sense of where you guys are in terms of implementing some of these value-based payment models now. You don't have to give us. I mean, what we're really trying to get a sense of is where you're at, what makes you a little nervous about moving these toward these things, and what do you think we need to understand about how value-based opportunities are rolling out in Nevada to help us better have a better sense of clarity into what you guys are facing in your market and how that might impact future endeavors to work together through some kind of a network construct. So first we want to kind of, and this is, I always tease everybody, but this is the audience participation portion of today's session. So we want to really get you guys talking and really hear from you directly. So let me start with just sort of asking, what type of value-based payment arrangements are you guys currently in, and who are the payers you guys are participating with? And I can see you, so I'll start to call on folks if nobody jumps in.
Hi, this is Walter. First of all, oh, I'm sorry. Can you hear me?
No, go ahead. Yeah.
I don't think we know what we don't know. I mean, I don't, still an understanding of, how this will be different than what we're already doing and coming together as a group. What challenges or what difference will be made from a financial standpoint? What type of resources that we will have to create this type of environment? And I like to understand, from others that you have worked with, what have they accomplished in that? And maybe that can help us formulate, are we ready for it? And what do we need to do on each one of our own organizations prepared for it?
Sure. I mean, I think it's a really important question, and I think a lot of it will vary based on, there are a lot of factors that influence that. One is how much of sort of existing value-based work you guys are doing now in your individual contracts. What can be leveraged when you start to build the kind of scale that Andy was talking about, sort of those $5,000, $10,000 markers. Typically what we see, Walter, is when networks first come together, the types of payment arrangements that they're looking at usually are around those quality incentives or some kind of a care coordination payment that are, because of the scale that you guys are working at, you have a greater ability to pull in more of those gains back into the network and then distribute it out to the health centers, because you can just negotiate better terms with payers when you're talking about, sort of those $5,000 and $10,000 marks. Part of what we're trying to do in this part of the conversation is to understand what are you guys currently doing, because that helps us understand kind of what the base or the floor is for where we might go with payers in the future. If you guys decided to go into a full engagement with us, part of what we would do would be a more involved pro forma where we really broke down specific payer information and did some modeling. But, we've had health center networks, around the country successfully pull in, significant increases in what they could have been doing individually, because they're able to create more both accountability and clinical consistency across that network. And that's one of the things that the payers are interested in, is knowing that they're going to get consistent value from the network rather than working individually with specific health centers. I mean, I hesitate, and I don't know, Andy, if we have like specific dollar amounts that, because it may not mean as much just hearing a dollar amount, I don't, but what we are seeing generally as networks start to mature, they're able to pull in more and more of those quality dollars and to some degree start to contemplate things like shared savings, because they've got more infrastructure in place to be able to take on those types of upside and potentially downside risk.
And I can,
Andy, if there's more you want to add.
I can just speak to that when we get to the section of the presentation today where we talk about some of their peers. And I can get I can go into a little more detail on kind of how they've structured contracts and what they look like.
This is Kathy at Nevada Health. I would be interested in knowing if you could provide some specific examples of where you've done this and what the benefit and value has been to the individual health centers.
Yeah, and I think we'll get to that a little bit later in the presentation. As Andy mentioned, we're going to go through some case studies with 3 or 4 states that we've worked specifically in, and what their return on the process has been. But we're happy to do that. Yeah, and again, every market has different advantages and opportunities that are presented to them. So we'll kind of give you a cross section.
And so, I think also I'm trying to get my head around how does this work from the patients, because each one from a quality standpoint, it seems like we all have to have a concentration on how we manage, the different, let's take diabetes, for example. Is there something that each one of the health plans wanted for diabetes and where our scores are? What would the group do to help with that? Because I'm sure everybody has their own model that they're working with now, so we'll just have one platform for entering the data for all the different payers. I'm trying to still figure out how this works. I'm still a little confused on it.
I have a comment.
So is anybody going to answer my question, or is just out there?
So Andy, if you can't hear me, just jump in. Typically what happens, and what's really important, I think, for you guys to understand, is when these networks are formed, the board and the governance and the decision making lies within the health center leadership themselves. So what you guys would ultimately, if you choose to move down this path and to develop this type of a network, it would be all of you making decisions about what clinical programming look like, what accountability look like, what you were using as metrics, and what you were mutually investing in. Typically what happens in the early stages of this type of network development is that you are building off of what you guys have as best practice at the health center and at the PCA already. So we're not looking necessarily in the early stages to have net new programming or net new structuring of clinical expectations. You would rather be just identifying where the best practices are within the network and what we can be doing to, should you guys decide to consistently apply those practices. In very few networks that we've worked in, and I think I've been part of this process over 30 times, is the, hold on a second. So what we typically have is an opportunity for you guys to make those decisions about what that would look like. So, we usually start, particularly around things like diabetes, where there is a lot of already a lot of work been done at the health center level, really looking at what you guys have in place and figuring out how to create consistency around those types of programming. So it's really about building off of what we have done initially, and you guys making decisions for the for your patient populations that make sense to meet those contract requirements for the payers. Also keep in mind that the way that we typically structure these is the care of the patient still remains with the care team at the health center level. This isn't about a network taking that part of the responsibility over. So again, those decisions would be things that you guys would decide, and that there might be things that make sense to mutually invest in to create some economies of scale, but chances are it's going to be building off best practice that you guys already have put in place through patient-centered health home and other population health strategies.
So do you have a readiness survey or questionnaire that if you pull all the information in again for each one of us, and then you can do an assessment, are we ready as a network to even take on this challenge right now? And what stages we have to go through?
When we engage in the process of, right. Yeah, so when we kind of go down this path with the group. Oh.
Sorry, Amanda.
Go ahead.
Walter, I think so. If you all decide after this session that you want to keep exploring, we do a couple of different pieces of data gathering. We do survey all of the health centers, and we ask about both like priorities that you may have with engaging with payers. So like things that are challenging about your current MCO relationships. After we provided a little bit more background about what a network could do, we ask you to prioritize which of those services or service lines sounds is a priority for your health center to have support in. And we look at we ask you for payer data, and we look more at your UDS data to tell you both like from a expressed priorities from the health centers, what may be feasible for all of you, and then also looking at financially how many lives you have with each of these payers and what the options may be. And if I this is backtracking a little, but what you were at your question about kind of what does this look like with a specific patient population, like diabetes, for example, like what we've seen networks, some problems that we've seen health centers face is, say, each health plan that they're working with has their own different quality measures or their own different approach to working with you on quality of care and value-based payment programs like pay for performance or something like that. And health centers, it may not work with your care model, or the incentives as the plan has structured them may not actually be effective at moving the needle on quality of care. And so the major benefit of a network coming together is that you have more influence to have that conversation with the plan, because instead of looking at 300 patients or 400 patients or, you know, however many you may have, you have all of your collective, you know, the plan is more inclined to have conversations about changing their own patterns or programs when they're looking at a greater volume of their own attributed members. And so that's one place that folks come together. And then also, you know, sometimes that other types of ways that you can work together. I think that was the root of your question. You can correct me if I'm wrong, but just sort of like, what does this practically look like? It's not so much changing your care model, it's pooling your collective voices and being able to say, you know, you want us to focus on diabetic care in this way, but what you're asking doesn't actually achieve the goal that you're looking for. So let's approach it in this new way, or something like that. Does that make sense? Does that answer your question?
Yeah, I understand what you're saying. I think that we're just all at different, you know, growth and, you know, and these particular, you know, spaces and everything else. I mean, for us, we have a kind of a whole, you know, unit that deals with this, and you know, business intelligence, you know, component as well too. So we've updated our contracts and all those kind of things. And I know that maybe you know, I'm just trying to see what value would bring to us as a, you know, individually as well as collectively, how to continue to expand those kind of conversations. So I hear what you're saying. I'm just still trying to figure out if we're ready as a network to explore what that will really look like.
You know, I'm just curious. This is Sharon. I'm curious, kind of along the lines of Walter. So let me just make sure that I'm understanding this. I feel like we've had so many conversations about it, and I still get a little confused. So forgive me. But basically, we're all coming together so that we can collectively get a better contract and negotiate better contract terms with these entities. And then the part that worries me is that, Walter, I'm going to make you the bad guy because I like to pick on you. But what worries me is that, for example, you know, suppose that Hopes is really great at managing their diabetes, their diabetic patients, and let's say Walter's entity is not. And so then, you know, we're sharing his risk, right, and sharing his downside with him across the whole network, which would impact us ultimately negatively. And so I think that's where I get a little hung up is understanding that piece of it, because what we would need is that everyone perform extremely well so that we can benefit the upside piece. But if somebody's not performing well, then we're all suffering across the whole network.
I think that's well said, Sharon, and you know, and then I think we all have to have a certain level of staffing to achieve those goals. So we can talk about it as a combined organization, but who we have doing the work to make sure that we can accomplish hitting our targets and what needs to happen. So
you, and this is Andy, you guys are, I mean, clearly hitting on some of the hard discussions that you'll need to have, whether it's through this process or otherwise, before deciding whether to do this. But I do want to just stop and say you're absolutely correct. The organizations that have done this throughout the country that look kind of like, you know, the makeup of your association, have agreed that they're going to work together to raise essentially everyone's performance to an acceptable level and gain as a result of that leverage in the market. There's a couple of things that I would typically introduce as kind of just thought points at this point. First and foremost is, you know, chances are, I would guess, based on the look at, you know, the limited look at data that I've seen, that some of your organizations might have a hard time getting beyond basic value-based payments simply because of total number of lives. So, you know, if you wanted to participate in value-based payments, but the plans weren't interested in doing that at that level, which they may not be, then who would you work with? and we see two options. We see an option of working with typically hospital-centric type IPA or PHO organizations, or forming your own. So that's if you want to move into kind of the value, more aggressively into the value-based payment arena and need a larger vehicle. So I would argue you'd have the same challenges working with a community-based or regional entity that wanted to do this, with less of, I think, the governance and control over it. Working together is not easy, as you've indicated, but if you decide to work together, there are going to have to be, and we'll talk about this, specific levers that bring people up to a certain level of performance, as well as certain levers for moving people out of certain contracts if they're holding the group down. But that is in essence what your peers who have decided to form this have done. The second thought point I'm going to put out there, as you kind of consider this, is it may no longer at some point in the future be whether you want to participate in value-based payment, but being forced into participating in value-based payment. And we want you to have the understanding that regardless of where each of you may be starting at today, a year, 2 years, 5 years down the road, having made those investments and really having a value proposition of what a health center is related to the network standards, related to the network's programming, et cetera, is the kind of investment that sometimes doesn't materialize in 6 months because you can get a good contract, but materializes in 5 years because you've invested in consistency, and now you can go after those big contracts. So it's not an easy decision, and we're not suggesting that it's an easy decision. We just want to make sure that you're aware that we know that these are the right decisions to be deliberating.
So with
Yep, and I think that.
So Sharon can, assist me in helping increase and improve my, diabetes scores. What's to stop us from, getting together, going directly to those payers and saying we're working together as a unit of the network to make that happen as a pilot? Maybe 3 of us get together, challenge this, and then bring it back to the group, and then add on as individuals. I mean, the other smaller groups coming together at the later time, but just kind of really understand and manage that process a little different, because that's what the health plans have done. Is even in a hospital setting, I can recall the hospital contracts were different than the group contracts, and when the hospital and myself got together and said we're going after them together, we were able to achieve a better contract because we were all in the room together. So I think that's the same type of model that you're thinking about, but I think we have to understand what resources we have in each of our organizations to be able to manage the process and what that flow looks like. So there's a whole lot of work behind the scenes that has to occur. And so I think an assessment of what we have and how we're doing it now, because you're right, if you only have a few patients in that particular insurance plan, they don't pay attention to you, but they pay attention to you when you're a much larger scale. So I understand that concept, but I think we might think about, some of our conversation after the fact is that maybe we do this as a pilot and have a few of us kind of get together and talk about what that looks like and build the infrastructure first to see if we're ready for that.
Yep. So, I mean, I'll comment on it. There's nothing preventing you from starting smaller. We've seen that work. We've also seen, 100% participation work, even though there was variation at the onset. That variation isn't something we're going to solve on this call. And so we're going to try to lay out a process for you that really does get to that, and where we can actually start to make some, or help you make some decisions about how to get started if a pilot is warranted, for example.
So Andy, I think maybe just in the essence of time, we should pretend. Go ahead.
There's one more comment, I think, but then we'll move ahead.
You mentioned earlier that if somebody's not performing, that they can be removed from the network. Who would determine that? Who would determine who gets removed, and who would determine who's performing well or not?
So typically that would be a board of directors made up of the CEOs of the health centers that are participating, but it would not be subjective in the sense that the levels of performance would be determined up front. And never have we actually haven't had a group removed for poor performance, because there are many other tiers of kind of how you work towards more uniformity in performance than simply kicking people out. But networks do reserve the right to do so. And any network we've worked on is a network governed by and for health centers. So it's the health center leaders who decide that.
Sharon would have the sole responsibility of kicking us out.
All right, let's get into some of the specifics now. Bear with me, I'm going to have to just share my screen again. So we've already gotten into some good conversation about what this might look like. I want to take a quick step back from that and actually look a little bit at different network structures, so that I want to make sure everybody has a sense of what we're essentially talking about. As a general rule of thumb, networks or health centers that come together to do this are looking to really drive value in a couple of key areas. The first is improving the health outcomes of the communities that they serve. And I know that each of you do this individually, but networks will typically really work to help optimize what that looks like. In our experience, networks have been more successful in leveraging new data sources, specifically payer or managed care organization created data sources, such as claims data, utilization data, attribution data, risk data, et cetera. The network might look to create some programming to support efficiency, or simply create standards for what that looks like, meaning we may not have a program at the network that does certain aspects of the work, but might insist on, for example, I heard someone mention earlier, certain staffing levels around care coordination or other programming. A lot of networks get started early on, working to increase their ability to engage patients. One of the value propositions to the plans, quite frankly, is being able to get patients essentially at the table and engaged in their wellness, because we know that that can lead to better utilization of the system. And networks will interact with the managed care entities to look at ways of creating sustainability in care delivery. So if you have community health workers, or you have diabetes nurse educators or clinical pharmacists, how can we find ways that are not necessarily tied exclusively to visits to sustain essentially those investments at your local health center? The next major area is in reducing unnecessary, ineffective, or redundant utilization and cost. I mentioned already, you can only really do that once you have a sense of where that cost is coming from. Some of you may have access to detailed claims data. Typically, we don't see that as a possibility until there is a network that's kind of consolidating a number of lives, if you will. The idea of looking to build and leverage kind of shared resources for addressing high-risk patients. We've seen networks leverage, for example, shared telehealth specialty networks, or even clinical pharmacists. Implementing proven methodologies for reducing readmission by chronic disease. So implementing where a high number of certain chronic disease patients like congestive heart failure or diabetes exist, look at implementing some programming to reduce their burden on the system. And then strengthening overall health IT. That doesn't mean necessarily in any way consolidating IT systems, but strengthening essentially how health IT supports the work. So consistent with, I think, a lot of the things that the PCA has been tasked with, but doing so through kind of an entity that has a specific focus on maximizing the investment in health centers when successful. And then lastly, is operating in efficient models ourselves, because the total cost of care is made up of both what gets spent outside of our four walls, but also what gets spent within. We've seen some networks look towards consolidation of certain services, whether that's shopping for health insurance together, doing some revenue cycle management work, et cetera, or even just having an outsourced and delegated credentialing function. Sharing best practice, again, something we know that the PCA is actively involved in, but really kind of putting that on a more aggressive timeline, if you will, simply tied to having financials basically dependent upon it. And then one of the areas we've seen networks derive a lot of value for themselves and the populations they serve is even having the ability to articulate risk, specifically social determinants of health risk, to the to the plans in a way that they probably don't have good visibility into now, and that really helps them understand the need for additional resources for community health center patients. So collaboration, as we mentioned, does not need to look like pooling and risk sharing all of our lives in a way that exposes us heavily to the performance of others, but it can and often does. And so there's kind of a gradation, if you will. So one way of piloting might be to do everything with a small group of health centers. Another way of piloting might be simply to move further down this trajectory. You see the trajectory on the left. We could look at just doing some basic shared services and or resources, but that could probably live within current environments. Strengthening data access, analysis, and integration. And that's there are some resources potentially to do that called health center control networks that you may or may not be involved in. Exploring safe value-based payment models such as basic pay for performance, which can theoretically be done directly. That may or may not warrant or require a basic IPA or ACO model. And then expanding standardization in care delivery, which is really where you start to get to the point where you can participate in some joint risk sharing, whether that's the risk of losing an upside only incentive, or if there's actually some downside. It really depends on what you negotiate for and what's available in your market. And then lastly, what we consider to be kind of the end state. Not necessarily everyone will get there or need to get there, but achieving a level of clinical integration, and we'll talk about what that means, that really gives you kind of unlimited opportunities to work together to define payment terms and models. And clinical integration is a legal status that allows for you to interact in the purchasing landscape, essentially in the negotiation with managed care plan landscape, as if you were a single entity while you get to retain your autonomy. And we'll talk more about that later, but it does allow you to execute some much more sophisticated leverage strategies in negotiations with health plans. So I just kind of laid out what a trajectory typically looks like. I am going to define for you the different types of networks that we've seen form. We tend to try to get away from this kind of alphabet soup and really focus more on what your goals are and what level of collaboration you're interested in, and then really look to help define something that we think is going to be most valuable in the environment that you operate in. But we'll talk about each of these. MSOs, really, designed to support health centers, but not necessarily to share risk. IPAs are organizations that do look to form joint contracts across their membership, but typically need to do so over and over again with different payers. And ACOs are accountable care organizations that typically are utilized to leverage a specific program. So if the state of Nevada created a Medicaid ACO program, then you might want to look at forming an ACO. That's not the case right now, so that one may not be as relevant. Let's just talk quickly about what each of these are. Just in terms of what an accountable care organization is, you're probably pretty familiar with this. A lot of this came out of work that CMS did really early in kind of some of the most recent round of health reform. But it's a group of independent providers who essentially voluntarily work together to try to better coordinate care, typically focused heavily on chronically ill patients, with a goal of creating financial efficiencies and improving outcomes. And when they're successful, they reap the rewards essentially through financial incentives. And some of your peers are operating this type of model and have been very successful, to the tune of bringing in several million additional dollars per year to be shared amongst the hospitals on a relatively small Medicare population. The model that we're most likely going to explore in detail is the IPA model. And this model is useful when you do want to work together, but you want to retain your independence and autonomy, but still be able to negotiate as if you were a larger entity, essentially that you had more patients than any one of you individually has. There is typically some shared business infrastructure. Again, that's not everybody using the same EHR, but there are some components that need to get built. Credentialing is a good example of one. And there is typically a need to adhere to certain standards. So you won't even offer necessarily participation to an organization unless they can meet a bare minimum of standards. And that typically those standards will change over time, which leads to the need to have rewards for performance and sanctions up to and including removal from a network on both sides of that equation. We'll talk a little bit about the different models that IPAs organize under. You may have heard of some of these. One is the messenger model and one is the clinically integrated model. And we'll talk about both today. Managed service organizations, again, are typically just entities that do a piece of the work on your behalf. And so they don't necessarily get involved in the actual creation of contracts. So let's just say that you wanted to build a small shared services capacity to evaluate performance against contracts and make recommendations on how to improve. You wouldn't necessarily need to pool your risk to do that, but you could share a resource to assist you with that. And that would be more of a managed service organization or MSO type approach. So we're gonna pause again, and Amanda, if your audio is stable, we'll have you do this, and if not, we can figure out another way. But do you want to we want to do a little discussion of which of these
Sure.
you may be familiar with, and if you're already participating in some of them.
Sure. And, sometimes it's helpful for us also to have a sense of how you guys have worked together previously. Another example of an MSO that we didn't really talk about, but is not as pervasive in Nevada, but is in other states, is the health center control network model, is another example of an MSO. It's a group of health centers who have come together to create some shared services around, health information technology and EHR. So we'd love to get a sense from all of you, what experience do you have with any of these network types, and what's your experience been like? Has anybody been involved in IPAs or ACOs or MSOs in the past? So no.
We
None
already
at
hear
this
me.
point. Nobody's really.
Can you hear me?
Yep, we can hear
Hi,
you.
this is Roxana. Hello?
Hello?
Hear you.
Okay, so I think we are all somehow involved with one of these programs. So in our state, we don't have that many options per se. Where we're talking about ACOs, I do believe that we have 3 or 4 in town. And in my experience working with ACOs, I don't think they're doing a lot for their clients. So just myself, I will look at that right now as an option. So between MSOs and IPAs, I think we have the potential of coming together and create one of the two, depending on everybody's, what they're looking to do and their organization, their numbers. So based on the numbers you presented, I do believe that most of us, we have more than 5,000 clients in Medicaid, which means that we have the numbers to negotiate even individually with the plan. But if we come collectively, I think the potential is even higher. And I know we have to look into the numbers, how the positive and negative measurements, the outcomes per se, but we also have to look into when we try to reach out our patients, sometimes they empanel patients, and let's say that we have 5,000 and maybe we can only see in 2,000. So that's another thing that can negatively impact our numbers, basically. So we are now working with a couple of HMO plans, let's say Optum, maybe some of you guys are working as well. And the problem I've been having is trying to find out how can I collect my RAP at the end of the month if they're paying capitation, because in our state, we don't have that many FQACs. When we call Medicaid, we don't have that many people that can actually answer questions to us and how can we implement that and how can we get the payment we deserve. So that's one problem I'm having when collaborating with HMOs as we speak. And by looking at the numbers you presented also, I can tell you that we are not focused on the Medicare clientele because you only show like over 7,000 clients. And I do believe that we can do better than that, and Medicare can exponentially help us to bring more Medicare patients. We can bring more money to every health centers by trying to put together these contracts and making sure we serve the community and especially the seniors. So we all want to maximize our revenue. We want to provide high quality care. And so I think that we are all in the same page, what we need to, what we would like to accomplish by coming together. So I'll say that we have many options before we jump in, so we can actually share, that we monthly receive reports from our MCOs like Anthem, HPN. We can maybe share that data and try to work before we join, in the network to see how can we best, maximize those numbers and make sure we're doing better. And we can actually focus also in a few measurements and trying to do better in some of them collectively, because it's really hard to have good numbers in all of them. So if we can focus on some of us in some of them and the other ones in another one, I think collectively we can show better numbers to the state, because every time I have meetings with CEOs and each plan, that's their concern. Yeah, you're here to negotiate something, but the numbers, they don't look that great in general. And I know we have the same problem because I might, let's say I have good numbers in diabetes or high blood pressure, but I might not have good numbers in other ones. So I think we all have the same problem, even though we can do well on one or two. And it's also because we are understaffed. That's a lot of work and a lot of people checking the data and finding out how to resolve it. And as we see right now, it's really hard to hire people that actually knows what they're doing in terms of data analytics. So we can also maybe share and have maybe a Nevada Primary Care Association or hire someone that can help us put together that data and let us know how to make it better. Instead of paying individually, we can look into that as well. And like I said, I do see a lot of potential in Medicare patients that we're not looking into, and we are just focusing on Medicaid, and Medicaid pays less and less every year. And I have a question about, I know since 2015 we have the MACRA. I don't know if that program is included in under one of the categories that you already explained, the 1 to 4.
Yeah, so macro would be a form of, oh, go ahead, Andy.
No, please.
There are different components to MACRA, and some of them would fall under category 3, 2, 3, and 4. I think there's there's different aspects of that program that fall into each of the 3. One of the things that I wanted to just note that I think you raised, Roxana, that I think is really important is there's a lot of emphasis when we start these conversations about, concerns about reimbursement levels and shared accountability, and those are all totally valid, but it's interesting that some of the challenges that you're talking about having with the health plans themselves are some of the initial things that networks take on behalf of their health center participants. Issues related to patient assignment, consistent reporting, creating an analysis between what the plans say your quality outcomes are versus what your clinical data is saying that your quality outcomes are, having some shared data resources to look at things like total cost of care and overall quality metrics. Those are all things that we see health center networks like these taking on in the very first stages, because it is so critical that we even get those fundamental pieces right before we start talking about more advanced contracting models. Those are things that can be advantageous across the health center, because it's been very rare that we've seen even very large health centers in different markets being able to really get to the bottom of those issues with the payers successfully on their own. And also what we find is that payers often have knowledge gaps themselves on what's going on with these data sets. And so really being able to have conversations on behalf of a group of the providers that they're contracted with to try to fix or address some of these issues creates a level of efficiency for the plans, as well as for the health centers that would be potentially within the network that are not necessarily quantifiable through contract gains necessarily, but we find it's a really critical piece of what these networks do initially, particularly in cases like yours where you're looking at a reprocurement period where you're going to have new payers coming into your market, and you're going to have to be establishing models for data sharing and patient attribution. It really puts the network and the health centers in that network in a better position to be having those conversations with plans as they're submitting their RFPs to the state. These are what our expectations are as providers in your network. This is the kind of data that we want. This is the quality check that we want on those data. This is what we want patient assignment to look like, within the scope of what's permissible in your, under law in your state and all those kinds of things. So those are, I think we tend to go very granular into kind of pay for performance or shared savings models, but understand that there's a level of value back to you all and to the plans that has that is linked to your payment and to your gain sharing that is more fundamental than that the networks can bring. And I'll stop there, Andy, and see if you have anything else to add. But Roxanne, I think you really highlighted a lot of the things when you think about the kinds of opportunities that we think is probably fair for your state too, but we really appreciate that. So Andy, I'll invite you to just pipe in and then see if any other folks have other thoughts.
Yeah, nothing to add. Thanks, Amanda.
So this is Mary from Canyonlands, and we have recently, we're in Arizona, as you know, and have our location on the border. So we've recently moved into a network. So we've had all of the different ACOs, value-based contracts with commercial, mainly Medicaid, and limited Medicare Advantage plans. So as moving into the network, what I'm really hoping is going to happen is they're going to take over dealing with all of the different plans, because what I found is that it's kind of overwhelming because we don't have a specific person that is able to work these contracts. We wear multiple hats in our smaller FQHCs. So that's the advantage we're hoping to see out of moving towards a network. Is being able to. We also have a wonderful population management tool that we really started before we formed a network using amongst all of the healthcare centers, which is Azara, and we've found that to be I found it to be very helpful in managing and comparing ourselves and kind of seeing where we're at. So that's just what I added.
Yeah, and it's very common to want a core function of any network to be to simplify your life as it relates to dealing with multiple health plans. And so I think it's easy to think of leverage as getting more money, leverage is getting better contract terms, but leverage could also be getting your payers to align on your incentive measures. It can be getting your payers to give you data in standard formats. And it can just be having somebody at a network whose job it is to get on the phone once a week with the plan when things aren't going well. So there's a lot of ways that a network will look to simplify that, essentially simplify that relationship, and really will want to be able to be in a good position, a good contracted position, but also a good relationship position with any and all payers that that their health centers use, realizing, particularly in commercial, there's a lot of plans out there. There's a lot of smaller plans. You're probably not going to have that with every single plan, but you do want it with the ones that are kind of your predominant players.
Right.
And Amanda, you had mentioned that what types of networks. So we do not have a state-run HCCN, as you know. 4 of our health centers are participating in the Arizona HCCN, which is what Mary was speaking about. So, and that has just started in the last year. So I don't know if anybody wants to speak to their experience with them, the HCCN.
Well, I mean, I just think that's, again, one of those things, if we were to go further into the process, understanding kind of where the capacity, lives within what the Arizona HCCN brings to the table. And that's very common in states where we have, states on the border, with another state, health centers on a border with another state, potentially, participating in multiple networks because they might have patients that span, across 2 states. Certainly because of the health center control network program requirements, there's a minimum number of health centers, that can participate. So it's not uncommon, where states with a fewer concentration of health centers are in other states' HCCN. So those are things that just become part of the fabric of the analysis that happens. And that if we were to continue the conversation with you guys, we'd want to dig into that a little bit more. To Nancy's point, find out what's working and what isn't working. If anybody's participating, for example, in a Medicare shared savings program, helping us to understand that, because that encumbers your Medicare lives, under that contract. And so we'd want to look at that when looking at analysis. But I appreciate that. And thanks for clarifying that, Nancy. I think we've talked a lot about some of the challenges about working within some of these network constructs already, I think, in our earlier discussion. So unless folks have other particular opportunities or challenges that you think are important for us to think about as we continue through today's conversation, I'd invite you to talk about those now. Otherwise, Andy, I'd say we can move on. Okay.
All right. We've mentioned the terminology clinical integration. We're going to take a quick pass through what that looks like. It is one of the predominant models of working together, and it is really specifically designed to address the fact that no 2 organizations are starting at the same point. We start this conversation by saying, we think you're going to be very likely to be participating in a clinically integrated network at some point in your future. And that really gets down to that shift I mentioned earlier, where there may be opportunities now to participate if you choose or if you want to in value-based purchasing. But we anticipate that all health centers will be exposed to value-based payments at some point in the future, and in many cases will be required to do so through some type of network or some type of aggregator. Some of these are going to be hospital-centric, and that may be okay. That might be the right decision in your community. As we mentioned earlier, we want you to have a sense of all of your options before really feeling pressure to be being forced essentially to make some kind of decision. Others will be formed and managed by health centers. I think I have a slide that shows just how prolific that model is, the health center-led model, in terms of the number of states that it's operating in currently. So in many states, health centers have already done this. And our first involvement was actually with the state of Missouri, the Primary Care Association there, and that's nearly 7 years ago. And so they formed a network 7 years ago, and it's still operational today. And we'll do a little bit more of a dive on them later in the presentation. Clinically integrated networks give health centers scale in their programming and their legal ability to engage payers in joint contracting activities. We're going to talk about what that looks like now. This is what I was talking about. This is data from 2015, and you can see that many of the states in green, or all the states in green, but many of the states were in 2015 already in process of either operating or participating actively in ACO or IPA models. Roughly, a third not doing so, and then several exploring the process, but not yet doing so. Well, this is our attempt at the kind of most recent data, and even this has evolved somewhat. And you can see that by 2020, the overwhelming majority of states have actually formed some type of network. And in many other states, there's still kind of some exploration going on. Tennessee, Kansas, Oregon, all very actively exploring. And then there are still a handful of states that have not done so, and often for a variety of reasons, very valid reasons tied to essentially their environment. But the point of this, and by the way, this is based on the 2015 data and then enriched with our own data, having worked with many of these organizations, that in even just the last 5 years, a lot has happened, and a lot more health centers have come together under this type of model. So we're going to define clinically integrated network, and a clinically integrated network can be any of the network constructs you saw earlier. An MSO can be clinically integrated, an IPA can be clinically integrated, and an ACO can be clinically integrated. But essentially, and this doesn't sound drastically different than the definitions of any one of those organizations, it's a group of independently owned and operated health provider organizations that work together to improve outcomes, reduce total cost of care, and improve patient experience, allowing them to participate in joint contracts, receiving important protections from antitrust claims at the federal and state level, and really look to expand the capabilities of all of its participants such that they can all perform at an acceptable level to maximize the reinvestment in all of their peers and in their own health center and in the health centers that they're collaborating with. We often get told that the term clinical integration sounds really dramatic, and we want to make sure that you understand that that's not really the case. We're not talking about trying to turn into the Veterans Administration with standard EHRs and clinical protocols, and everybody has to operate the same way. It's a legal standard, and it's a legal standard that's tied to having essentially a set of requirements for participation such that you're not just letting any organization participate. Part of our process with you folks will be to explore to what level to look to integration as an appropriate model. But if you recall on my previous slide, it is kind of the end state that most organizations try to get to, because it really does give you the most or the least limitations on how you can go about contracting in the market, and thus the most leverage in the market. I mentioned we were going to explore clinical and financial integration. I'm sorry, clinical integration and messenger model. There's another model we want you to be aware of, and it's the financially integrated model. And essentially, the Federal Trade Commission and the Department of Justice, who oversee antitrust law, will actually give you an exception if you're financially integrated. Now, financially integrated is defined as bearing enough common financial risk that those entities would deem it necessary for you to be kind of collaborating in meaningful ways in order to manage that risk. We don't like this particular model for health centers for a couple of reasons. The definition of substantial financial risk is not particularly clear cut, and most interpretations have that meaning essentially exposure to downside financial risk. We wouldn't recommend any group of providers coming together for the first time in a downside risk contract. It's just too much exposure. And to perform under financial risk contracts, we would suggest that you would still need to build the same infrastructure that would support a clinically integrated model. You wouldn't take on financial risk unless you thought you had some tools to help everybody manage to that risk. The last model, and I'm just going to do 2 quick slides on this, is the messenger model. And you've probably heard about this. We're not particularly big proponents of the messenger model because the messenger model is essentially a loophole in antitrust law that allows a single entity, in this case the network, to negotiate on behalf of a group of independent practices, provided that they don't share information about each other's contracts, and the negotiation is done on an individual basis with each individual health center. So while you can get some basic economies of scale by having the same people doing the work, you're not gaining any significant leverage because you're not joint contracting across all lives under a certain contract. Messenger models, just to reiterate, do not have the legal ability to discuss, share, or negotiate contract terms deemed competitively sensitive across a group of health centers. So you can't get in a room and talk about rates. It's not allowed. You need to be in one of the integrated models to do so. So in addition, just a couple of other things to think about with messenger models. They do require creating a separate entity that's consistent across all of these. We'll talk about that later. Typically, they operate on a fee-for-service model because you're not pooling the rewards, so there's no way to pay for the operating expense except for the health centers to directly pay for it. They may build some services, usually under a fee-for-service arrangement. But most of those who, and some of your peers did start in messenger model, most have then moved on to become clinically integrated networks. They found that the messenger model did not deliver the value they were looking for, which was group bargaining and support for how to execute against contracts. And it's not drastically easier to administer, and does pose antitrust scrutiny challenges just simply by its nature and how it operates. It's not necessarily that we're saying this is off the table. We told you we have no foregone conclusions about what you guys might decide to do together, but we will steer you in our process. We will steer you to understanding what it is you're really trying to accomplish and which of these models essentially supports that the best. I'm not going to spend a lot of time here. Again, if you've seen us present before, you've probably seen what we refer to as our value equation. And really, the network should be focused on anything and everything that can help either increase quality, thus increasing value to the plans, decreasing cost, both cost of your organization to the plan as well as cost of everything else to the plan, which we refer to as the cost of us and the cost of them. Help you really understand and make risk work for your organization and for the patients that you serve and for the contracts that you sign, as well as giving leverage and scale and being able to articulate a statewide group of providers that all meet a certain threshold of performance. And there's, again, I'm not going to spend a lot of time here because we've already talked about a lot of these, but there are all sorts of different services or capacities that a network can build to support you in that. You can also drive that value equation simply by modifying your standards and the incentives associated with those standards. So we're about to start to dive into what some of these actually look like. And we're going to get into some, just a handful of brief case studies about actual peers of yours that have gone through this. When we refer to a horizontal network, an ACO or IPA as being horizontal, it means the participants in that network are comparable to one another. And that's the case of, like, for example, you as health centers coming together under a common network model, because even though there are differences, you look more alike than you do different from one another. You know, that network would then look to put some services in the middle that support clinical performance, operational excellence, and financial performance. The alternative is and you know, we've seen horizontally organized ACOs, but the historical perspective of an ACO was that it would include all sorts of different types of facilities. So you'd have academic medical centers coming together with community hospitals and specialists and home health and FQHCs and primary care physicians, and really look towards you know, really look towards kind of a community-wide model. And again, this is a valid model and it does exist and it can work well. But one of the challenges that we find when health centers participate in these models, first, you see it at the bottom, they're typically asked to kind of operate at the highest level of acuity or risk, typically because they're seen as having the capacity to do so. The other is you're talking about a governing body that's made up of essentially all of these different players, and not having necessarily, nobody ends up really typically with much leverage, although generally the largest organizations have the most in these models. So, you know, getting back to, for example, just the idea of how do you know, what happens and who makes the decision if somebody needs to be removed from the network. In a model like this, it's most likely not your individual organization. So that's some of the downside to these models, is our ability to have considerable leverage over them. Clinical integration is a lot about consistency. So payers like consistency because they know that if they send a high-risk chronic disease patient to one of your facilities, if we can offer them some level of consistency in how we'll care for them and ultimately the outcomes that they'll receive, they're more likely to send more patients to us. Patients actually benefit from clinical integration because it typically does involve creating, again, some consistency. Now, they're not going to seek care in multiple of your health centers. Typically, we know that that does happen, but typically they're not seeking care across many of your organizations. But some of the programming that health centers put in place, for example, around patient engagement, for example, around maybe home monitoring or telehealth, benefit the patients directly. And providers, and in this case, your organizations, benefit because typically a clinically integrated network is able to provide quite a wealth of information and data to the organization for both managing contracts, achieving results, and improving the health of populations. So we'll go through each of these. These are the seven pillars of clinical integration: participation criteria, performance improvement, data and information technology, joint contracting, the use of appropriate legal entities, a flow of funds, and clinician leadership. And then each of these has to have its own accountability platform to make sure that those that are participating essentially meet the requirements of each. So let's talk a little bit about these and why they're important. Participation criteria, one of the most important pillars of clinical integration, says that a network must be selective in choosing its participants based on a set of standards. Those standards should help ensure the network is likely to achieve its goals. In virtually all cases where antitrust claims have been successfully brought against networks, it's been because they have chosen not to be selective and allow really anyone in. And if you do that, then that can really lead to essentially diminished performance across the network. We realize that you as an individual organization will continue to maintain a performance improvement plan and nothing about that will change. But clinically integrated networks should demonstrate that they too have a performance improvement plan. And oftentimes those will dovetail nicely with the plans at each of the local organizations. We have said several times that typically none of your peers at this point have moved to a single EHR. Some have explored it and some may go there eventually, but it is not required. However, virtually all networks have some form of shared data and infrastructure capability. Typically that starts with interacting with the data from the plans. So, aggregating EHR data can be expensive. It can also be a little concerning as a first step. But getting data from the plans and getting it, normalized, cleaned up, and in the hands of the health centers as efficiently as possible is really a good spot or a good place for networks to start. Networks enter into contracts as a single entity. And so therefore, its participants are successful together or they fail to achieve incentives together. But that is a hallmark of an integrated, ultimately integrated network. And we hit on that early in the conversation to say, yeah, that does mean that we're exposed to other people's performance. Critically important, and some of you may remember earlier managed care attempts that focused much more heavily on cost and thus kind of rationing of services. Networks are typically required to demonstrate that there are clinicians making high-level decisions on behalf of how the network operates and on behalf of the standards that it adheres to, really to make sure that patient needs are prioritized essentially over financial rewards. Flow of funds demonstrates that sufficient investments in the infrastructure and capability of the network have been made such that the network is a key player in helping the health centers achieve their goals, but also probably the more interesting part of the flow of funds is the idea that the funds flow back out to the participants when the incentives are earned. And in any case where you're looking to do any kind of contracting together, we can't stress enough that you should be using a separate and distinct legal entity from the PCA and any and all of its members. And that really does have to do with liability, both financial liability and liability for antitrust. Not every network, not every health center network is going to have the same participation criteria or the same joint contracts. But part of developing or designing and then ultimately developing a network is figuring out how to check some of the boxes in each of these 7 areas in a way that that really creates the opportunity to prove clinical integration and be in the market contracting together. And the thing that wasn't on there, those were the 7 pillars, but then I mentioned being wrapped in kind of an accountability framework. Creating a network is about agreeing to hold each other accountable to certain standards of performance and operations. There was a question earlier about who does that. The answer is that you will. As health center leaders, you will be accountable for building that accountability platform and then ultimately administering that accountability platform. Your best opportunity to do that is to get good contracts that reward performance and then dovetail or mirror the standards in your contracts to how the health centers earn their incentives from essentially the network. And we'll talk specifically about the Louisiana network that did just that in their Medicare arrangement and did quite well as a result. By utilizing a network, setting up an effective governance model and determining a flow of funds tied to performance, you create ways of working together while still incentivizing enhanced performance. So we can find a way to work together even if we're not starting from the same standpoint, but we want to make sure that we are incentivizing everybody getting to the same level, or at least moving in the same direction. I mentioned your peers who have done this successfully have had a long-term strategic view. We want to build a pro forma that shows that we're likely to achieve financial sustainability quickly, but the real reward for doing this comes much later as the system continues to evolve and we have a platform essentially for interacting with the managed care system in a more meaningful way. I've talked a couple of times about these examples and I'd like to kind of go through them. As I mentioned, Missouri was one of the first to move, really because of some of the same trends that you're seeing in your market now. Now, they didn't expand Medicaid, but they did bring in managed care, and they brought in managed care that had a specific goal of contracting under value-based payment arrangements. So they formed their IPA in 2013. They leveraged infrastructure at their HCCN, not essential, but they were able to do that, their PCA, and really build out a pretty robust platform for collaborating. Within their first year of operation, they secured contracts with all 4 Medicaid managed care plans that increased, for every health center, increased the amount of upside financial exposure they had to value-based contracts, and have been operating ever since. Not, there are always going to be some bumps in the road, but this is an organization that's derived considerable reinvestment in its health centers by holding those contracts, helping the health centers achieve those contracts, and then reaping the reward, including using the same vehicle, not a separate entity, but the same vehicle to enter into the Medicare Shared Savings Program in 2015 and drawing down over the course of time several $1 million for doing so. Louisiana had a somewhat similar story, a little bit inverted. Actually, they started in 2016 with the Medicare Shared Savings Program. They utilize an outside party. We don't necessarily endorse them, but they contract with an organization called Aledade that supports their ACO. They too leveraged HCCN and PCA infrastructure. And when they got really good at generating shared savings in Medicare, they decided it was time to it was time to position that same process and infrastructure towards the managed care plans operating in their state. A third, and again, these folks now they are still in negotiations on the managed care side, so that's new to them. But they've been very financially successful under their Medicare Shared Savings Program. Iowa has a little twist to their story. And Iowa is a relatively small association. I think they have 13 health centers, whereas Louisiana, I believe, has over 30, and Missouri at least just about 30 health centers. Iowa has just about 13. They initially formed a statewide ACO of health centers and entered into a Medicaid-sponsored shared savings program in their state. Shortly thereafter, their state shifted to an MCO, and actually the network was a highly relevant concept to that shift. As the managed care plans came into the state, the network was already functional, had already had a track record of success, and was able to get good contracts pretty quickly with those managed care plans. Their particular network does play a role in supporting data management and also supports certain care coordination efforts at the health centers. The health centers are doing the care coordination, but the network is helping to define and prioritize essentially how it works. So all three of these are kind of long-standing models that have achieved their goal of reaping a financial benefit for their members. But I think most of them would tell you that the real benefit has come in, kind of in the clout that the health centers have within these states, really to be able to position health centers where health centers wish to be positioned on this kind of managed care continuum and value-based contracting universe. So Amanda, if you don't mind, why don't we just have a little discussion around this last section, and then we're going to get into the process of exploring a network.
I've got a quick question.
And go ahead.
I just had a quick question. This is Sharon. So just make sure I'm understanding. So for example, for the messenger model with IPA, that every health center would be negotiating their own individual rates, and in the integrated clinical care model of an IPA, there would be. Are you saying that there's one rate across all health centers?
So let's start. There's a couple of things I need to kind of break down, about this question. A clinically integrated network would have the legal right to negotiate any and all aspects of your compensation, including your base rate. Most of them do not. Most of them, because of PPS and other APMs that states are under, most of them, in fact, rely on the PPS to make up the majority of the underlying base rate. A little different on the commercial side where we don't have PPS protection, in which case some of them are doing that. But it's important to understand that just because a network moves towards integration doesn't require them to contract on their base rates collectively. So you can avoid that topic altogether by saying we're only going to work together on the value-based portion of our contracts. And that's what many, if not most of your peers have done. The second part of your question though is if you did want to negotiate on base rates, do you have to have the same rate? And the answer to that is definitely not.
Okay.
A clinically integrated network could negotiate for simple uplift against current rates. It could look to set minimum thresholds for rates. It could look at setting a standard rate, but it doesn't. There's absolutely nothing that says it has to, and we wouldn't necessarily recommend it at this juncture because of the federal protections around PPS. If that were to change, I think the answer to that question might change quite a bit. I think most organizations would look to contract for base rates together, but I think that that's the exception right now, not the norm. I'll always remind you that if you do this, it's you guys that make these decisions. It's certainly not us. We typically aren't involved once a network becomes kind of mature and fully operational. So it's certainly not us making those decisions. You guys would make the decision as to whether you wanted to negotiate for base rates. You would make the decision as to whether to do that on a percentage basis or some type of flat fee or what have you. So there's a lot of flexibility and what we call option value, the option to do things different ways as a result of having a network that you might not have had otherwise. So yeah, I just wanted to make sure I clarify that for you. Is that helpful?
Yeah, very much. Thank you.
Yep.
So I think, just with respect to kind of where we are from a time perspective on today's presentation, I just want to sort of see if folks have that was a really good question, Sharon, and one that's important I think to clarify. Do folks have other opportunities or concerns or challenges as it relates to some of these concepts around clinical integration that we can address before we kind of move on to the last part of our discussion today?
I think one of the things
Andy,
that is a positive for an opportunity for us, because it's so easy to focus on all the stuff that seems extremely challenging and integrating. But one of the opportunities is that it could very well just improve patient care for our individuals that are accessing services at health centers across the whole state, because we would be collectively working together to improve on certain measures and sharing much more information and ideas. And in that way, ultimately, with the mission of health centers and what our hope is, I think that's certainly an opportunity.
Yeah, I think that's great. I think part of the decision-making process is really at what point do you need a separate entity to do that, or can you start down? Maybe you decide at the end of this process that you're not ready to go all the way to shared contracts, but do you start down that process, like you said, of focusing on some of the same goals so that someday you can ultimately do that?
Yeah. And one of the things that I just want to say, one of the nice things about being in a shared network when it looks to sort of setting clinical priorities is that you have access to much richer data sets as a group that come from payers that allow you to drill down further into some of the metrics that they're looking at that you wouldn't necessarily have visibility into. But that doesn't necessarily mean you have to jointly contract on all those things. You might just have an arrangement to kind of share data together and look at that and identify some targeted clinical interventions, probably building off things you're already doing, frankly, but creating some scale there without even necessarily going all the way to joint contracting. So, but you have to have some of those arrangements in place so you can legally do that. Sorry, Andy, I'll let you go on.
Okay. So we have a little bit more time with you. Our final set of slides talks about our process, and then we will have time to wrap up with questions and answers. But there's been a lot of discussion about, we like to start the conversation off at the highest level. Here's what's happening in your environment, then kind of work through what have others done to respond to it. Now we're at the point where, with that context, we think we can talk a little bit about what process we recommend for you folks to go through to determine what might be a good option for you and frankly, what might not. And the process has a couple of specific goals that I think tie to a lot of the concerns that you folks have raised. First, is evaluating two really critical components to this. Number one is there a business case? And the business case tends to be pretty dollars and cents, although we will incorporate some non-financial business value that would be derived from working together. If there's no business case, it's going to be hard to have much of a motivation to work together. But without motivation, the best business case in the world will fail and collapse. And motivation gets to, are we willing to collaborate? What will it mean to collaborate? How will we handle certain issues if we collaborate? And for example, somebody's bringing us down. And it's really important that we do this evaluation in such a way that gets to both of those goals. So in order to facilitate that, we take a deeper look at your payer mix. We want to do that with your data for a variety of reasons. One, we know it's newer. You've probably seen growth. Not everything necessarily maybe got reported on UDS. There's a variety of reasons to look at, very specifically your data around payer mix. And then both between the survey process and a set of interviews, really understanding readiness and motivation for participating in a network and whether it might make sense in your state. That's the first step. And then beyond there, it really does begin the prioritization of needs as it relates to some level of integration. And maybe integration isn't the end goal. Maybe we don't necessarily recommend going all the way towards having shared contracts, but we want to help pinpoint where the business case has the highest value and where it aligns with people's motivation to work together at this point in time, which typically then gets revisited. If you take a small step, then you'll revisit when is it time to take the next big step. And if we can define that in such a way that we can identify what its legal and operating, kind of components and requirements are, then a next step of really kind of vetting some early conversations with health plans to kind of vet and validate the business case and really get a sense for what might be possible based on working together. So I've kind of already spoken through these, but I just want to hit a couple of other points. Business case, so if there is a business case, it suggests that financial sustainability and the ability to contribute to the participant health centers is likely. And it's derived by analyzing the potential for value-based payments to the network and then ultimately to the health centers. It may include some cost savings, cost avoidance, or economies of scale. We generally don't build those, the business case off of those, certainly not exclusively, but really we rarely try to articulate that. I hate to say it, mostly because health centers don't necessarily believe us. And then in a couple of years, they look back and they say, man, we're so glad we have that payer relations person in the middle, because we know we were each spending a lot of time on it. The willingness and motivation, as we mentioned, you can have the best business case in the world, and if people aren't motivated to work together and willing to work through some of the hard issues, it ain't going to happen. So, doing this does involve doing some things consistently across our organizations. It does involve taking a hard look at our own individual performance as well as the performance of our peers and making tough decisions about how to interact in the market. I mentioned kind of legal and operating requirements. Later in the process, if there is a business case and the motivation to work together, now we have to put pen to paper on what the organization will look like. And that organization has its own separate governance, almost exclusively, in most cases, exclusively made up of people on this phone call. The people that are going to essentially steer the business. There's two kind of critical documents that get created. One is an operating agreement, which defines the governance structure and decision-making process. The second is a participation agreement, which essentially binds each health center to the network and defines some of those policies, procedures, standards, et cetera. Then the network has to go about developing its operating model. So what are the things that it actually does to support its health centers? How does it enter into the contracting conversation? What ancillary services will it provide essentially to support its members? So we've laid out for the PCA essentially a three-step process The first being doing some basic information gathering and education. That's today. The second being really looking at that business case and motivation question, assess some of the readiness, assess some of the willingness to work together. And then a third step that really gets into, okay, if there is a desire to work together, what does it look like from a legal and operating standpoint? And I mentioned that part of the process may involve engaging some payers. Typically, we don't want to do that until we have at least a little bit of a vision for what it is that you'd want to do. And you'd want to have some very cautious conversations to get a sense of their willingness to work with various networks before you make the investment essentially in developing the network. This is a process that we've seen, and in terms of the 3 phases that I just talked about, typically we're getting you basically to the end, give or take, of the structuring and a little bit into the integration phase. We've seen this done as quickly as a total of about 10 months. Typically a year is a pretty realistic goal. We've seen other organizations take a lot longer. And in fact, we've had multiple organizations that have started the process, put it down for a period of time, restarted the process, and then were ultimately successful in achieving it for valid reasons. For example, the delay of a managed care, the introduction of a managed care program in their particular state. So these are approximate ranges for what it takes to go through this process. We're actually already pretty well along in this process in terms of the external market scan work that we've done just to get to our conversation today. And so, should you move forward, we'll be spending a lot of time in the evaluation and structuring phases. Next steps, should you choose to move forward, there's a series of conversations and activities that'll occur. I mentioned there's a survey that gets into specifically some of your payer data, as well as into some of the current capacity that you have or desire in order to engage better with managed care. We conduct key informant interviews. We do those individually so that you can feel more, you can feel free to be more open about your concerns, and we can bring that back in aggregate form to the group, not individually. We conduct some data analysis once we have the survey and other data sources, and as well as research into the environment. Generally speaking, in the second phase, we do some additional member engagement, specifically some additional webinars to really introduce some of these concepts to a broader subset of your leadership team. We'll get into a little bit more detail than we've gotten into today on some of the concepts, specifically concepts like how do you govern this and how do you create a flow of funds model. We'll continue to vet and analyze essentially the business case. We'll refine the business case, and we typically recommend that you transition accountability to a member oversight group. Now, you folks are a small enough set of health centers that theoretically could involve every health center, although that would typically be kind of on the large side. And this is just a group to help steer PCA staff and your consultants on how to be most valuable and effective in designing something for the network. And that results ultimately in a strategy session where we put some initial recommendations on the board. You help us further refine them, and then usually build towards a decision as to whether to move forward with some type of network or, frankly, not to. And so that concludes any of the formal discussion today. So with that, we will turn it back to you folks. I don't know if the PCA wants to, anyone at the PCA wants to chime in first, but we'd love additional questions, feedback, comments, and then we'll let you folks go.
Andy, thank you so much. It is a lot of information, but this is all information that we need as a group to decide how we're going to go forward. I think it's really good information to have as we go into our strategic discussion in September. So I don't know if we'll have an answer for you immediately, Andy. I think there's a lot of thought that needs to go in. We unfortunately lost one of our board members who had an electrical outage at his building. So he will need to listen to the rest of this presentation. But I mean, it's just a lot of topic. We have recorded this, everybody. So if you want to listen to it again and share it with some of your staff members, that is an opportunity for you. Just because I know that I'll want to go back through the slides again and look at them and understand them greater. Do you have any questions for Andy or Amanda?
Well, I want to know, do we have the slides available to us?
Yes, they were emailed out to you this morning, Walter. So look for an email from Hope.
From Hope? Okay, thank you.
Any other thoughts or questions?
Just want to say thank you, Andy, and for everyone else that was on the call. I think it's important for us to be thinking very strategically about this, as you know, the changes are coming in the next whatever set of time, but it is nearing. And I know that we've had the conversations before, but I feel more educated and informed, and you know, look forward to having the discussion at the board level about how we might proceed or continue with some kind of analysis on it. So thanks so much for taking the time today.
You don't think we have any more questions, so.
All right. Well, thank you, folks, and we look forward to working with you, and we'll talk to you soon.
I thank you so much.
Take care.
Bye, guys.